posterior surface modification UV ozone treatment was evaluated. The mechanism of the IOL is that there is an increased adhesion of fibronectin and lens epithelial cells to the posterior IOL surface, which promotes the IOL adhesion to the posterior lens capsule and prevents PCO. So we wanted to assess the PC IOL optic adherence in surface modified IOL and its impact on NdY capsulotomy rate and visual quality. It was a prospective interventional study conducted at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. 93 eyes with immature senile cataract grade 2 to 4 were implanted with hydrophobic acrylic IOL with posterior surface ozone treatment after phacoemulsification. Cases with ocular or systemic comorbidities were excluded. The primary outcome measure was posterior capsule adhesion to the IOL optic as assessed using anterior segment optical coherence tomography and the NdY capsulotomy rate. Secondary outcome was visual quality assessed using ray tracing aberrometry. Follow-up was performed on postoperative day 1 and 2 years. So the mean age of patients was 59.46 plus minus 9.14 years. 37 were bilaterally implanted, 19 were unilaterally implanted. No case had any intraoperative posterior capsular rent or vitreous loss. At 2 years, 94.6% had an uncorrected distance visual acuity, corrected distance visual acuity or 20/20 or better, and 100% had CDVA of 20/32 or better. So this is what we observed on AIOCT. On the left hand side, there's a case with a complete PC optic adhesion at 2 years. So initially the configuration of the PC was smooth. There was a 497 microns distance between the IOL optic and the posterior capsule, which decreased to 80 microns at 1 year, and at 2 years there was a complete PC IOL adhesion. In this second case, there was a wavy configuration of the posterior capsule with around 255 microns fluid. It decreased to 137 microns at 1 year, but the fluid persisted even at the end of 2 years. 96 microns was left. So on post-operative day 1, only 2.9% cases had complete PC to IOL optic adherence. At 1 year, this figure increased to 67.6%, and at 2 years, 73.5% had complete PC IOL optic adherence. That means nearly more than 1/4 cases still did not have complete adherence. So Zhu et al. Had evaluated PC optic adhesion in visual axis after phacoemulsification, and what they observed was that 41.5% had complete inadhesion at 1 day and 7.1% at 2 months. So as per them, 93% at 2 months had complete adherence. However, they used stream plug imaging, which is less sensitive than anterior segment optical coherence tomography, and it may have underestimated the real incidence of PC optic inadhesion. So why is it important? The residual PC optic distance positively correlated with the total higher order aberrations with a Pearson correlation coefficient of 0.4 and a p-value of 0.03. So Strail ratio, modulation transfer function, and root mean square total aberrations were significantly better in cases with complete PC optic adhesion. Coming to posterior capsular opacification, it developed in 7.5% cases at 2 years. So this is just an instance of a peripheral PCO with clear visual axis. 92.5% did not have any PCO. What's important is that in the 7.5% cases that developed PCO, 85.7% had persistent PC optic non-adhesion with a p-value of 0.001, and NdY capsulotomy was needed in 3.2% of cases. These had PCO obscuring the visual axis, and all cases that required laser capsulotomy had persistent PC optic non-adhesion. So to conclude, surface modified IOLs are expected to have higher rates of PC optic adhesion with less PCO. Nearly 2/3 of cases at 1 year and 3/4 of cases at 2 years have complete PC optic adhesion. However, 1/4 of cases still have persistent PC optic inadhesion, and complete PC optic adhesion leads to less posterior capsular opacification rates, superior visual quality, and no need for NdY laser capsulotomy. This was the first study to characterize PC optic adhesion using high definition AIOCT in a surface modified hydrophobic acrylic IOL and correlated with visual quality and NdY grades. Thank you for a patient hearing.
Yeah, excellent study, something new. I have few questions actually. Have you compared those lenses, hydrophobic lenses versus these lenses, adhesion rates? This is out of the study. I'm just asking
yes.
of this thing. Yeah.
That I have not presented.
Yeah, but just out of this thing. Yeah.
And they have the comparison which we have done, which we are also writing. They have a much better PC optic adhesion rate
on day
as
1
compared to this.
On day 1, Is it compared to that Zhu et al., which says that almost 40% on day 1 and 90% by
No.
1 month?
Significantly more. The inadhesion is significantly more than as reported by Zhu et al. They said
Because
that
of
at
the
2
you
months
cannot
majority
compare
got.
oranges with
Sheep
apples.
plug with
Because,
ASO. Sheep plug is very gross, sir. 80 microns, 70 microns you don't see on that.
But hydrophobic are better adhered to the PC at the end of 2 years.
Surface modified, yes.
So what's the rate? Have you compared
At
it?
2 years, this is coming nearly more than 25% still had inadhesion. In hydrophobic, at 1 year, around 80 to 85% had complete adhesion, and 2 years, almost all had complete adhesion.
The second question is, you have done bilateral surgery also.
Yes, sir.
So have you noticed any difference in the laterality, let's say for left eye more PCO than right eye? This is out of my experience I'm asking. And I have asked this question to many surgeons.
It's an interesting thought. We can analyze
you can implement
it
it.
again.
You can implement
because we
it.
have the CPs of all. I'll try to see if I can find
because
something.
what I have observed over last 15-20 years is I get more PCO in left eye.
Okay.
And I am doing superior phaco.
Okay.
So you can just compare. Maybe you can.
Okay. You're a right-handed surgeon or
I'm a
left-handed?
right-handed surgeon. Yeah. For a right-handed surgeon, more PCO in left hand
with a superior.
With a superior approach.
Okay. Thank you, sir.
Yeah, thank you. Thanks a lot.
Can you help a general ophthalmologist who doesn't have ASOCT
Sir,
for the assessment of the
for
PCOs?
assessment, clinically you can see.
You can see.
Yes.
Okay.
On a slit lamp, you just have to make a fine slit. 80 micron, 60 micron, will you be able to pick up in all cases? I'm not really sure.
Okay.
But gross inadhesion, you can see the wrinklings, etc. are visible.
And what is the cause of fluid between the posterior surface of the lens and the posterior capsule? Is it the fluid which remains? What is that? Any difference in surgical technique which you have noticed?
No difference in surgical technique.
The surgeon is the same. The technique
Surgeon
is the same. Machine is
series.
same. Single surgeon series.
Single surgeon series. Yes.
Interesting. Interesting. Yeah. Thank you.
Sir.
Thank you, Dr.